Hi everyone. I'll present here some cases, my cases. The emergency surgical treatment of diabetic foot attacks, the emergency situations, and they have necrotizing fasciitis, and I'll show you what I have done with DEBRICHEM. If I can, yeah. So, 11 cases, all the stories, the treatment, and the results, and I'll just summarize them here. They're not too old. The mean age is about 58 years, and they're mostly male patients. The diabetes duration is, again, not too long. It's around 15 years. The wound onset is important. It is mostly the acute exacerbations of chronic wounds. My patients were like this. And I performed minor amputations in 5 patients. That was only toe amputations, and some of them with metatarsal head resections. I didn't do any major amputations. And microbiologically, I can culture in 5 patients some definitive microorganism. And I did percutaneous angioplasties in 6 patients. We required to do that. And the time to closure of the wound, which is grafting in my cases, I always graft the patient to close the wound. The mean time was 61 days. That was applicable in 7 patients. The others are still in the clinic or in they're following up. The main therapy was first resuscitation, because those patients are not regular chronic wound patients. They're in some state of sepsis. So IV fluids was the soul of the treatment, which plus that I initiated a triple anticoagulant, antiplatelet therapy immediately. And prompt surgical debridement, drainage, prompt surgical intervention was the soul of the treatment. It's like 1 hour and 20 hours after the initial resuscitation. And I used 60 seconds of DEBRICHEM in every patient. And broad-spectrum empiric antibiotics were initiated because, again, I should remind you that those patients were in septic shock, no, but sepsis, definitely. And repetitive debridement went on bedside or in the operating theater during the course of the treatment. So those are the pathological results in Turkish language, but which you will see there's the same medical terms: abscess, necrotizing, active inflammation, ischemia, suppuration, phlemonose, necrosis. That are, those are the things that I can objectively show you that how serious were those patients. Let me remind you the Lirinek score. Maybe you're familiar with it. It's not for diabetic foot, but it's for necrotizing fasciitis differentiation from other soft tissue infections. So it looks at these 6 parameters, and it's a validated tool, and it has a positive predictive value more than 92%, I guess. Those 6 parameters are, calculated, and you get a score, and you can say the risk of necrotizing fasciitis in every patient. Those are the laboratory findings of those patients. That are the 6 parameters that are included in the Lirinek score. And you can just, the A1C levels are mostly at 2-digit A1C levels, poorly controlled diabetic patients those were. And this is the summary. Like a mean CRP value was 220, and hyponatremia, high glucose levels, and leukocytosis. According to the mean value, their mean Lirinek score was 10 out of 13. That is a strong indication of necrotizing fasciitis and its septical consequences. And the hemoglobin A1C level was around 11%, that is really high. And every patient, the mean is, you know, I have 6, I have 4, 10, 11, mean is 8.45. After the initial therapy, surgical intervention, and DEBRICHEM application, on the 7th day, it was 3.2, that you cannot talk about a necrotizing infection anymore in 7 days. So this is my patient number 1, which has a Lirinex score 6. Well, it's like intermediate risk of necrotizing fasciitis, but you can see the abscess there. And you can see how it affected, the infection affected the soft tissue and the bony structures there. The purulent drainage you can see on the left side, and sharp necrosectomy was done, and the application of DEBRICHEM. And this wound is really extending to the heel of the foot, which you will see on the next day. This is day 3. It was all infectious purulent drainage, and the patient was in a septic situation. And on day 3, those tunnels, those surgical instruments are touching calcaneal bone. It is probe to bone positive patient. But I have, you see, fresh granulation tissue just on day 3. It was, you know, a war area 3 days ago, but now it's like granulation is thriving there. And day 10, more granulation after negative pressure therapies, and I have still the tunnel. It took me some time to close those tunnels, but at the end, I could graft it all the way to the heel and the defect there. And this is the patient's last photo that he was, you know, on the follow-up. He's not walking. He didn't lose any toe, even, you know. And this, let me say, this patient referred to us from a peripheral hospital that was a below knee amputation was offered to the patient. So he just rejected it and come to our center, and this is the result. And you can see the, you know, the CRP levels and the white blood cell counts are just, you know, that is on decline day by day. And this is a Lirinex 4, the lowest Lirinex score patient that I have. And you'll see it. It's the low 4. You cannot say maybe it is a necrotizing fasciitis, but it's not important. It's the clinical thing that matters. So you can see the pus. And this is a telltale sign for me for necrotizing fasciitis. If you dissect the plan with your finger, that is necrotizing fasciitis. No matter what other biochemical parameters say, what is the CRP level, this is necrotizing fasciitis for a surgeon. And you can see how it extends to even to the ankle joint there. Pus with necrotic material. Those are mostly the dorsal fascia of the foot that are coming along there. And you can see the borders there. It extends. But I didn't open all the way. I should have maybe for necrotizing fasciitis, but I was conservative because I was testing the acid. I was testing the acid. So it's a quick application. Somebody is counting down 60 seconds and then you're washing it off. It's a 70-year-old female patient, by the way. It doesn't take much time. I mean, it's like 60 seconds when you finish it. So that was day 4. I have necrosis, as you can anticipate it. Just necrosectomy there, but still have a lot of skin, still preserved a lot of skin. And just after 3 or 4 days, I started a true surgical debridement, and what is left as a fascia, I just take them off. Then negative pressure wound therapy. And I had PTA to the PTA posterior tibialis artery. So it was just enough blood for me to go on. That is day 12. Some more different types of debridements there. Scrubbing the wound. But I spared a lot of skin there, you know, because you can see the pockets there, but the overlying skin is intact. So that is what I get from it. But still, my finger can go to the ankle, and the patient has a foot and 5 toes still. Day 19, and day 52, the wound was like that. I just debrided it again and grafted it. Negative pressure wound therapy on the graft. I don't think that. And this is the immediate, this is a home taken picture from the patient after just 20 days of grafting. She's doing fine. The same type of graph for CRP and white blood counts, white blood cell count, it's like decreasing. Just remember that was a Lyrinek 4 patient, my lowest score, that the patient that with the lowest score. So my observations, I'm not going to be, you know, conclude powerful things, but extent of my initial surgery, I was very liberal to be conservative. I should have, as a surgeon, for all my patients, I should have be more aggressive, but I stay in the conservative side of to spare some skin, some tissue. Time is tissue, but sometimes you have to save tissue. You have to work to save tissue, to save the limb. And infection and sepsis, all the biochemical parameters were, you know, going well, good responses, but the mostly good clinical response, I'm a clinician, I'm a surgeon, you know, the patient started to eat after a day from a septic status to eating and drinking patient. And the wound, healthy granulation was, for all 11 patients, I achieved the healthy granulation tissue in less than a week. Red, pink, healthy granulation tissue. And time to closure, grafting was about 2 months, as I mentioned. So it's a good result for me with DEBRICHEM. So they say you cannot use DEBRICHEM on those cases. I used DEBRICHEM when everything was present, nothing happened. Diabetic foot attack with necrotizing fasciitis. First of all, this is locally a limb-threatening condition, but systemically it's a life-threatening complication. If you don't see enough patients like these, those patients exist. This is where the major amputations happen, in fact. If you don't see those patients in your clinic, your orthopedic people are working hard. That means that they're doing a lot of major amputations. And surgery is mostly improvisation. You have to, it says you have to drain it and debride it. Nobody tells you what to do because every patient is different. And you use standard products, like you just irrigate the wound. And my point is that DEBRICHEM can be a standard product for those kind of patients that mostly lose their limbs. In fact, even their lives, because if necrotizing fasciitis with sepsis is left untreated with surgical intervention, it has a 2-digit mortality rate, as long as I know, and I'm sure of that. So DEBRICHEM helps with that in emergent cases where diabetic foot wounds are heavily infected. And you see, most of the wounds were already present there. They were acute exacerbations of those chronic, those innocent-looking wounds. So that's all. That's all I want to share. Thank you.